intra-articular. The extra-articular are going to be the collateral ligaments. The intra-articular are going to be the cruciate ligaments. And we're going to do valgus and varus stretch tests or stress tests for the collateral ligaments, and we're going to do them again in 2 different positions. So just like the elbow, we did 0 degrees or totally extended, and then 30 degrees of flexion, and we're going to do that the exact same way at the knee, and for the exact same reason. With the knee flexed, the joint capsule is a little bit has a lot more tension to it, and the elbow was the opposite. With the elbow flexed, it actually took a little bit of tension off the joint capsule. With the knee flexed, it tenses up the joint capsule. And that's important because we're also going to do anterior posterior drawer tests with the knee really flexed, and then there's Lachman's test with the knee extended a little bit more and less flexed for the same exact reason. With the knee, the more the knee is flexed, the more the joint capsule is going to be tense. And when we're testing the cruciate ligaments, we want the joint capsule to be loose. Or sorry, the collateral ligaments, we want the joint capsule to be a little bit loose. So we also want to, just like in the elbow, test the joint capsule. So we have it at totally extended like this. I'll do it slow. So notice what I'm doing. Got just like the elbow. Kind of pinning it here like this, and I got my hand directly on the joint line because I want my hand to be the fulcrum, because I want this motion to happen, not this. I don't want that shear force to happen. So it's like I'm visualizing this is a stick and I'm bending it around my hand. So 0 degrees, push through. That way. Notice where my hand is. I know a lot of you are going to want to do this, and this is wrong, because you're putting pressure on the kneecap when you're doing this. See what false positive is. So this is kind of like Dr. Irving's yoga class a little bit. I'm teaching you how to use your body in different ways. So here, watch. Like that. Watch again. There we go. And breathe. Push through like this. Directly that way. What's that? Yeah. I didn't want to say the fancy word. What's back there? In a valgus direction, if you want to get real fancy. A little bit.
Ooh.
You had the, you damaged your MCL. That's probably it. Normally, you probably won't notice much movement, but we got some here. I'd have to compare it to the other side and say that that's abnormal or normal. Some people have floppier knees than others. Floppier. I don't know why. Laxity is hard for you to say. Everybody wants to say laxicity. Laxicity. Or laxativity.
Yeah, no, had you not said that.
Yeah, I know. Laxativity. I heard that one today, and I was like, I like that.
Laxity for just now.
Right.
Laxity.
Laxity. Not laxicity.
Like the city.
Sure, yeah. Remember it however you want.
Relax.
So now we got the knee flexed 30 degrees, and we do the same thing. Pushing in this direction. For varus, I just tell the patient, I'm going to need to stand on the inside of your calf here. Knee extended. Varus. Knee flexed. We have the same problem where the hip is going to move just like with the shoulder, or the elbow, the shoulder move. So just take it to the point where the hip actually stops, and then you can push through like that. So if somebody has a larger leg, not that anybody in here is going to need to do this, but you could actually do it this way. If I had a patient where their leg was really heavy, or it could be because of the like table height or something like that, I could hold the leg in between my knees like this, and then use both hands to do valgus and varus, and then flex the knee and do the same thing. So I want you to try both of those ways, because it could be beneficial. Now, I normally wouldn't say this, but over the last few years, so many people have screwed this up, so I have to. You wouldn't do that if you had a skirt on. You wouldn't do that if the table was too high and their foot was all up in your business. Please don't do any of that stuff in the final. Like, if this is the way you like to do it, don't wear a skirt. Like, it's really kind of annoying when that happens, because then I got to call you on something I really think is just you not paying attention. But if you're not paying attention here, it's going to be a very strange scenario in the clinic. So just be careful with this. Obviously, yeah, I got their feet between my knees, and if I was really short and the table was really high, that might put them in an awkward position. I wouldn't do that. It's just okay. All right. I have to, there's been so many people that have done that, I have to say it now. It kind of aggravates me that I have to go there. So be it. It's really a nice way to do it, even if the leg's not too heavy, because you get pretty good handle on the knee, and you can actually do valgus and varus without switching positions. So I do want you to try both, because there will be some patients where, holding their leg and doing it this way is just awkward for one reason or another. So now let me show you anterior and posterior drawer tests. So now we're going to be testing the cruciate ligaments. And the anterior and posterior drawer, this is a classic test for ACL and PCL. And this is done, it says the knee at 90 degrees. It's the foot on the table like this. And this is more than 90 degrees right now. It's just a little, it's probably like 100, 110 degrees. But really, it's just foot on the table. And that's where we started. Now, the reason we've actually refined this into Lachman's, or Lachman refined this test, is because this knee is pretty flexed. And with the knees really flexed, the capsule might create a little bit of tension. And really what we're looking for here is laxicity in this direction. No, I did on purpose. Laxity and excess movement anterior and posteriorly. When I'm pulling the tibia anteriorly, the cruciate ligament should eventually stop that. And same thing posteriorly. The cruciate ligament, posterior cruciate ligament should stop that. So that should, at the very least, whatever movement I have should be symmetrical. In addition, it shouldn't hurt. So we have to compare left and right as far as how much anterior and posterior shifting there is. And we also have to look for any kind of pain or reproduction of symptoms. So with this, we generally sit with kind of the upper part of my posterior thigh on the foot like that. Just kind of anchor it down. I'm not completely on the foot right now. I'm just giving it a little bit of a backdrop. We could also put a knee on the foot, but I wouldn't do this unless the patient had shoes on. For obvious reasons, because my knee might hurt at the top of their foot. So, usually do this. My thumbs are going to go right in the joint line, which in the anterior part of the joint is going to be just medial and lateral to the patellar tendon. The rest of my hand curls around the back of the calf. I pull until I get all the slack out, just like we did with the SI joint test, and then oscillate a little bit just to see what's going on. So I got a little bit, maybe 4 or 5 millimeters of shifting, and then the stretch at the end seemed like it was good and solid. What'd that feel like? Yeah? No pain at all?
Maybe a little something to say that.
All right. And let me do the other one. I just want to picture palpating the posterior. And I use my thenar eminences to push. Posteriorly. Push like that. Yeah, decent amount of movement. Thumbs in the joint line. Thenar pads on the tibial ridge. Push posteriorly. That's anterior posterior drawer. I want you to do it exactly how I did it. Like this. I don't want to see any other way is wrong. I see a lot of weird things with the thumbs. Why would you ever do that to your thumbs? I don't know. Or your thumbs are like that and you're hyperextending them. So get your hands like that. Nice and solid. We need to actually put it, especially with posterior, I put my whole body weight in there. Anterior is really easy because you just kind of lean back. Posterior, you got to actually put a significant amount of force in there. You can't just push it. It's the whole body weight in there. So now Lachman's, classically is done only for anterior cruciate ligament, although it's so easy to do anterior and posterior drawer again in this position that we do it. We do it for both anterior and posterior cruciates. So we flex the knee at about 20 degrees. Lachman had really big hands, and this is the way he did it. He grabbed the legs like this. For most of you, you'll be able to do this on camera. And then I'll show you an alternative way to do it. So the joint line in this position is in that vector. So I'm going to be pulling and pushing the tibia anteriorly and pushing the tibia posteriorly. Anterior and posterior. Any pain with that? Okay, so this is more specifically to ACL than the first one. The first one was definitely testing ACL, but we're getting a lot of joint capsule in there. That might be what you're feeling. Tugging out some of the superficial nerves. And what you should be able to feel is a little bit of clunking in that knee. We're not getting a ton of it. I think Michelle's kind of stopping the hamstrings here. What's that? No, the clunking would be normal. You're actually going to get more motion here because the joint capsule is less tense.
Are you stabilizing with one hand and oscillating with the other?
You can feel that, right? Yeah. And I can feel it too. It's just clunking is just things moving. You can feel just a lot more movement.
Are you?
What's that? Is it?
I mean, clunk, I think it's actually
Yeah. Good.
Are you oscillating with both hands or stabilizing with
Both
the
hands.
bottom hand?
Both hands are moving in opposite directions.
Okay, so is that like a shear force kind of
It is.
thing?
That's
okay.
what makes your posterior grows. So you'll probably notice more movement with that. You got to make sure you do it. So that's one way to do it. Just grab the leg, and I know a lot of you are going to be like, "How did you do this?" And you'll be doing things like this. So I'll come around and help you figure out how to use your arms. But another way to do it is just like we did with valgus and varus. And if you don't feel like you can get a good grasp of the whole leg, you can hold it between your knees like this, and then grab the femur and the tibia. Make sure that you got about a 20-degree bend in the knee, and do anterior and posterior draw like that. Yeah, it's easier to hold. I don't have to hold the leg up. It's easier. Just have to do this. Is that what you're asking, or what's the difference between this and the anterior and posterior? On the table?
Yeah.
That's it for anterior.